This video will cover the anatomy, introduction, pathophysiology, classification, clinical features, diagnosis, and management of spinal cord compression and associated syndromes. The spinal cord is about 40 centimeters long in adults, extending from the foramen magnum to the L1-L2 vertebral level. Anatomically, the conus medullaris is the tapered end of the spinal cord. The cauda equina is a bundle of nerve roots, and the filum terminale anchors the cord. The cervical and lumbar enlargements supply the upper and lower limbs. This image illustrates the various ascending and descending tracts within the spinal cord. The internal anatomy includes gray matter for cell bodies and white matter for tracts. Blood supply is primarily through the anterior and posterior spinal arteries, supplemented by radicular arteries, including the artery of Adamkiewicz. Spinal cord compression is the physical pressure or pinching of the spinal cord. This is typically due to injury, tumors, herniated discs, or other spinal disorders. Pathophysiology involves extrinsic or intrinsic factors compressing the cord, leading to dysfunction. Causes include trauma, tumors, infections, degenerative conditions, and vascular lesions. Other causes include inflammatory conditions like epidural abscess or tuberculosis, and epidural hemorrhage or hematoma. Clinical features depend on the location. Cervical compression affects the arms and legs. Thoracic compression affects the legs and bowel or bladder. Lumbar compression affects nerve roots, potentially causing cauda equina syndrome. Common symptoms include weakness, paralysis, loss of sensation, and loss of bowel or bladder control. Upper spinal compression may cause spasticity, while lower compression may result in flaccid paralysis. This image is a placeholder with no text content to vocalize. A spinal cord syndrome is a destructive neurological state that causes major motor, sensory, and autonomic dysfunction. It results from specific patterns of spinal cord injury, ischemia, or disease. Spinal cord syndromes are classified based on the anatomical and functional disruption. Complete or transverse spinal cord syndrome involves the total loss of function below the level of injury. Causes of complete syndrome include trauma, ischemia, and transverse myelitis. Clinical features are the loss of motor, sensory, and autonomic function, including spinal shock. The prognosis is poor if symptoms persist. Incomplete spinal cord syndromes include central cord syndrome caused by hyperextension injuries. Features include bilateral motor weakness, more severe in the upper extremities, and variable sensory loss. Brown-Séquard syndrome, a hemisection of the cord, causes ipsilateral motor weakness and contralateral loss of pain and temperature. Anterior cord syndrome, often due to ischemia, results in the loss of motor function, pain, and temperature while preserving proprioception. Conus medullaris syndrome involves lesions at L1-L2, leading to bladder and bowel dysfunction, saddle anesthesia, and mixed motor signs. Cauda equina syndrome is the compression of nerve roots, resulting in lower motor neuron weakness and urinary retention. Weakness, sensory loss, and autonomic dysfunction are the hallmark symptoms. Onset can be acute or chronic, and associated symptoms include back pain or fever. The physical exam assesses motor function, looking for upper or lower motor neuron signs. Sensory function is tested for sensation loss, and reflexes are checked for hyperreflexia or absence. MRI is the gold standard for diagnosis. CT myelography is an alternative. Laboratory tests like CSF analysis may be used for suspected infections or demyelinating diseases. Acute management may involve surgical decompression for compressive lesions. Steroids are controversial for non-traumatic compression. Radiation therapy is used for metastatic tumors. Supportive care includes managing bladder and bowel function through catheterization and laxatives. Rehabilitation involves physical and occupational therapy. Prognosis depends on the cause, severity, and timeliness of intervention. Incomplete injuries generally have a better prognosis than complete injuries. The next topic we'll cover is spinal shock. Spinal shock is the temporary loss of spinal cord function below the injury level following acute spinal cord injury. It can last for days to weeks. It is characterized by flaccid paralysis, areflexia, sensory loss, and autonomic dysfunction. The common cause is trauma. The mechanism involves the sudden disruption of descending spinal tracts, causing the loss of reflex circuits below the injury. Diagnosis relies on clinical exams showing the loss of reflexes. The bulbocavernosus reflex test is used to assess the end of spinal shock. Imaging like MRI or CT identifies injury severity. Treatment in the acute phase includes immobilization and potentially steroids and IV fluids. Rehabilitation focuses on physical therapy and managing muscle spasticity. For further details, please refer to Rosen's Emergency Medicine Clinical Concept and Practice, specifically the section on spinal cord compression. This image is a placeholder with no text content to vocalize.